Asunto que estamos de buen que vayamos a tener la
Okay. Good morning and good evening, everyone. I can see some of our audience have started joining in. Most welcome. And this is the Rebuilding Equitable and Accountable Health Systems in Post-Conflict Setting session. So we're going to give participants about 2 minutes, our audience to join in, and then we're going to start, if that's okay with everyone. Okay. Can you hear me? Great. All right. So good evening, good morning, good afternoon, everyone. Welcome again to the session, parallel session on rebuilding equitable and accountable health systems in post-conflict setting. I am Dr. Caroline Tatua. I'm a senior health system advisor working with the International Rescue Committee. But I've also had quite a bit of experience working in development as well as humanitarian setting. And right now overseeing health system strengthening in 4 countries, humanitarian setting in Ethiopia, Uganda, South Sudan, and Somalia. So most welcome to this session. Today we are going to have a panel discussion, a lively panel discussion. I have 4 strong panelists who will be joining me and we'll be chatting to see what their experience are in rebuilding accountable health systems, especially in conflict-afflicted states. Maybe just as a reminder, global and natural man-made emergencies affect over 270 million people every year, causing about 130,000 deaths annually. And these figures might be also much higher than we are reporting at the moment. And about a quarter of the world's population actually lives in countries affected by crisis and a violent crisis. So when we are thinking about universal health coverage, and which is really an important stepping stone to achieving the right to health, it's really fundamental. We cannot be able to make progress towards achieving universal health coverage unless we also critically examine what this means in conflict and fragile affected settings. We know that these settings have various challenges that really impact on their ability to meet some of the indicators already. Health systems that are devastated by maybe years of conflict or relentless crises that keep happening year in, year out. And with this, there is really a need to have a critical lens around how we can really bring them on board and together achieve universal health coverage. What is also very critical that we need to think about, and I'm really glad that AHIC has really had this session on focusing on a humanitarian context, is that we would need to really look at some of the stepping stones or some of the aspects, different perspectives that need to be considered while we're thinking about rebuilding health systems. A lot of the times, there's a lot of investment in dealing with the immediate emergency. Again, equally, countries do have a need to continuously strengthen the health system, to have investment that is looking at a long-term, equitable access by strengthening the systems we have. So today, I'm joined by 4 wonderful panelists who will be sharing different perspectives and points of view, mainly from government, from donor agencies, from NGOs and academia. And we'll be reflecting a lot more on South Sudan, which is a country that has been affected by years of crisis. It's a protracted crisis and post-conflict setting. And we will be looking at actual experiences and hearing from these panelists on what it would really take to achieve universal health coverage. So with me, I am going to introduce the panelists. Then we will go into a session where we're going to have some questions, and they will be giving just some guided discussion around this. I will ask each panelist to wave, as I mentioned you, just to be noted by the audience. We'll start with Dr. McCoy Samuel. Dr. McCoy is the Director of Preventive Chemotherapy for Neglected Tropical Diseases, working with the Ministry of Health in South Sudan. He brings on board expertise he has 20 years experience and expertise in public health, and very big focus on primary health care, health system strengthening, and community health, amongst other areas. He has held various portfolio in the Ministry of Health, and we are really happy to have you on board. So welcome, Mr. McCoy. The other panelists is Dr. Barbara Profeta. Dr. Barbara is a Senior Health Advisor for Global Program Health and Eastern Cooperation at the Swiss Development Cooperation Agency. She brings to this panel years of experience in humanitarian and development work, having worked with organizations like the Red Cross, the Red Crescent Movement, UN Family, and among others. So most welcome, Dr. Profeta. Next, I will introduce Dr. Morish Ojok. Mr. Morish Ojok, sorry for that. Mr. Morish is the country representative for AMREF Health Africa in South Sudan. He's a public health specialist and has worked with various international and local organizations in development and humanitarian setting in Asia and Africa. So most welcome, Dr. Morish. Last but not least, I will introduce Dr. Kawa Tong. Great to see you. Dr. Kawa is the Health and Nutrition Manager at CARE South Sudan, and she has years of experience in international development. She's currently the Deputy Chair of the National Immunization Technical Advisory Group in South Sudan and a member of the National COVID-19 Steering Committee. So most welcome, my fellow panelists. So to start us off, I'm going to direct a question to you, Dr. McCoy, just to set us up on the setting of South Sudan. So in your view, what has been or continue to be some of the biggest hindrances and challenges of viably rebuilding health systems in South Sudan?
Thank you, Dr. Caroline, for having me. Just a small correction. My title is Mr. McCoy Samuel Yebe. I think before going to the issue of challenges and hindrances, I think we probably need to step back and see where the country South Sudan came from. I think that journey is very critical for us to understand the hindrances and the challenges as the stakeholders in the country intend to build or rebuild a healthcare system. Now, this is a country that is born out of conflict, and it had been a very protracted and prolonged conflict, which actually decimated any existence of a health system from the old mother country, which was Sudan. And which, of course, sometimes probably it is better because it is easy to build than to rebuild. But with that comes the complexity of trying to build up a healthcare system. But let me start from the time of the CPA. I think with the Comprehensive Peace Agreement in 2005, and with the institution of the institutions of governance as per the dictates of the Comprehensive Peace Agreement, you have a Secretariat of Health from the civilian wing that's concerned with the health from the SPLM, transformed now to a ministry. And And then there was also the consortium of partners that were providing humanitarian assistance. And the humanitarian wing was actually probably more organized in its process of transitioning after CPA. And then and there was goodwill to start revamping the efforts of building or rebuilding a health system of the then government of Southern Sudan. And I think that process went through the the independence in 2011, where now you have an independent South Sudan with the Ministry of Health taking the mantle of building up a health system for the country. Now, while there was this goodwill and real effort have been put in place, that has actually provided real impacts. For instance, mortality rate improved, reduced. The child survival indices all improved. The ratio of health workers to population served has also improved. But the efforts of transition and rebuilding comes with its challenges of coordination. And I think now moving to the key issues that really challenges and hinders any viable rebuilding of a health system. One, there is the issue of the political transformation itself. The transition period from CPA to independent South Sudan was not a stable period. There was a political wrangling there. And secondly, there was also very weak institutions. Even though at the time there was already the first version of the health policy, which actually clearly articulates how healthcare services is organized across the different levels of government. But the institutions are weak at all levels. And the weakness in institution created a situation where it becomes difficult to coordinate effectively these well-organized humanitarian structures that have been built for many, many, many years during the conflict. And third, now there is the issue of dependence on outside support, external support, to build up a health system. To me, these are three critical main hindrances to building or rebuilding a viable health system in South Sudan.
Thank you so much, Mr. Majok. And just as a follow-up, I'll pose this question to Mr. Morish. AMREF Health Africa in South Sudan has been working towards equitable healthcare. And we've just heard from Mr. McCoy some of the issues that he's mentioned, especially around the coordination. So how does AMREF Health Africa in South Sudan promote equitable access to healthcare, and how do we link with what is the coordination like, and how does this link with what the Ministry of Health?
Thank you very much, Caroline. Yes, I'd like to say I'm Mr. Morris. I know you, when the doctors speak, everybody becomes a doctor, but yes, I'm Mr. Morris. I'm the representative of AMREF South Sudan. Now, building from what Dr. McCoy, Mr. McCoy has said over the challenges that are facing South Sudan as a country, we all know, it's a very difficult process, and it's a very difficult time to come from conflict and settle and build a system that can withstand some of the issues that the communities face. Because, the purpose for the health system is basically to support communities to withstand some of the shocks that come from the different environmental issues, like some of the things that bring weaknesses and poor health results into poor health outcome, breaks down the community. And some of these things are very evident in South Sudan. Now, AMREF has been with the government of South Sudan for a very long time. since 1972 when we set up an office in South Sudan. By then, it was still Southern Sudan. It was part of the main Sudan. And we were supporting health capacity building and health service delivery in the different parts of the South, where we set up a training school in Maridi Health Science Institute. The purpose for setting up that training school was basically to try and see if we can build capacity for leadership. And you know, in a state like South Sudan, in conflict setting like South Sudan and other countries that face similar situations, the issues of power, the issues of legitimacy of governance is a very big gap. And there are also issues to do with capacities and capabilities of the institutions that are in place to provide the basic services to the people of this environment. And AMREF has played a big role. So far, I think 80 to 90% of the health clinical workforce, the clinical officers in South Sudan, have been trained by AMREF through the institute in Maridi. And also, we have done quite a lot in trying to support the ministry at the national level when it comes to policy development and the policies that are conducive and better for the delivery of health services to the people who have very limited capacities in terms of finance, in terms of knowledge and awareness and all that. So we have supported different initiatives in policy development. We've also supported different initiatives in capacity building at different levels, at the national level, at the state level, and also at the community level, where we are now rolling out the Poma Health initiatives. That is linking the community to the care that they desperately need at the facility. So we've done quite a bit of activities. Now, when it comes to doing this, you require also some bit of inside willingness, politically, socially, culturally, and in all aspects. This still continues to be issues that needs to be addressed. For example, cultural issues that are emerging that prevent people from taking up care, that prevent people from exercising their rights to participate in planning, in decision-making for healthcare services. These are still issues that continue to persist, and I think everyone in the country plays a big role. And given that, as Mr. McCoy has put it, you see, in a context like South Sudan, you find that most of the healthcare services are NGO-led, for example. In South Sudan, we are seeing a situation where care services at the facility level, at the local level, are being led by NGOs, but it should be led by government, so that everything is done according to what the community desire and what the community, empowering the community to bring out their voice, to participate in every processes to deliver that care. I think at the moment I'll pause here, allow you to continue if there are other questions I'll answer. Thank you.
All right. Thank you, Mr. Morish, for that. And it's really great to hear what the work that is happening, but also the challenges as very much linked to what has been said by Mr. McCoy. I'll pose the next question to Dr. Kawa. So Dr. Kawa, you work a lot with civil society organizations, and we know that civil society organizations also play a very key role to really bringing, equitable access right from the grassroots all the way to the national level. So in your view, how can civil society organizations, or how are civil society organizations contributing in South Sudan to better equity of access to healthcare, especially in contexts that are marred with like insecurity? We do still feel it's post-conflict, but we still have been facing, of course, incidences of insecurity here and there, and where there's also social political marginalization of specific groups. What have civil societies organizations been doing, and how do they link to this bigger picture in terms of the whole nation? Dr. Kawa, we can't hear you. Sorry, are you muted?
Yes.
Good, great,
Thank you.
okay.
Thank you for reminding me. So I thank you, Dr. Caroline. In a post-conflict environment, whereby the health services is delivered by the civil society organizations, being the national NGOs or international NGOs. That is the typical case of South Sudan, a country in transition. Usually the most worrying sites when there is a conflict, people are left in the middle, not being helped. And if there is any help from both sides, they wouldn't trust because they are devastated. So they end up in the hands of the humanitarians, which usually the civil society organization, international NGOs or national NGOs. And when they end up there, the hundreds of these CSOs or national NGOs or international NGOs, they would be competing or eager to deliver the healthcare. I think the role they can play is as following. The first one that I would like to put up front is the coordination, the issue which Dr. McCoy mentioned earlier, the coordination. So instead of, for example, working in silos alone, nobody knows who's doing what where, I think the key issue is to coordinate, to know who's doing what where and who wants to do what where. The second one is the integration of services. So I'll give you an example. So for example, a civil society organization, NGOs, international NGO come, they want to deliver a nutrition service, for example, to treat, like establishing an outpatient therapeutic program for children who are malnourished. That is an opportunity to get the children to be vaccinated. So I think it is important to integrate and using every opportunity not to miss children or women in a given context. So I think integration is one of the key roles that we can play. Another issue is the data or the information. For example, carrying out joint needs assessment and disaggregate data so that we see to which extent are services being delivered and who is left behind and who is left out. Synergies, especially I would give you the example of human resource. So for example, investing in a frontline health worker who could be a community health promoter, and he or she can be trained in identifying danger signs of the childhood illnesses. So I think synergies, getting using whatever opportunities available for the frontline health worker is important. Also, multi-sectoral approach in service delivery. If there is a water point that has been set up in that given community, that is an opportunity for health and hygiene education in that water point or the safe drinking water point. So I think approaching the service delivery in the context of a multi-sectoral approach. I think also building the capacity of the locals, of the beneficiaries. And I think that usually ensures the transparency of the service that we are delivering. There are many international commitments. For example, the Grand Bargain. I think those opportunities, if we follow them, if we are part of it, if we take those commitments, those principles, I think we could play a big role in a transition context in South Sudan. So for example, the grant again talk about transparency and also the increase of coordination in terms of funds, and also to make sure that we reduce the duplication. So we wouldn't come three of us delivering EPI activity or doing maternal health activity. So I think it's important for us to reduce the duplication I already talked about joint needs assessment and enhancing the quality through which we need to reduce earmarking. So we come with $1 million only for water, all the $1 million only for water. We could reduce the issues related to earmarking and use that money, use the $1 million to a percentage of it to EPI, a percentage for it for maternal health and antenatal care, and a percentage of it for nutrition. So that's what I would answer for that question.
Right. Wow. Thank you, Dr. Kawa. And I think this is really food for thought, because it brings up the element of really having a robust system that's able to coordinate all these pieces. And I think it boils down again to how is this really coordinated? I'll go to Dr. Profeta. So just listening to colleagues on what they're saying, and we know that typically, especially for countries that are conflict afflicted or are facing crisis, a lot of investment goes into really dealing with the immediate emergencies that are happening, and quite often crisis takes away the kind of development mind that is needed to really build long-term sustainable, sustainable health service delivery. So I just wanted maybe to ask you, in post-conflict setting, how does a donor agency strike the balance between the short-term, the short-term needs of saving life, of dealing with emergency, and the need to really build systematically and strengthen, the health system, so that we look at equitable and accountable healthcare in the long term?
Thank you, Dr. Caroline, for the question. This is not an easy one to answer, because I think there are two things to consider. One is the conceptual ambition that many donors have and make public and pursue, and the other one is the administrative reality of the type of donor you have at hand. So I think it's important to mention that donors is not necessarily a collective denomination. Depending on the type or the nature of the funds you hold and you manage, you might have different types of accountability mechanisms that allow you to function. But if we look at the basic principle, I think that what has become popular already several years ago, this whole idea of working in the nexus, is precisely the type of ambition that would allow a donor to not have to strike a balance between looking at humanitarian needs and building systems in parallel. Unfortunately, I would say that the aid industry in general, and not only the donor part of it, has been trained since its professionalization to have a consecutive vision of crisis settings, a pre-conflict or a pre-crisis, within the crisis, and a post-crisis, when actually, in my own experience, the majority of these settings have the crisis as the normal. So there is no before and after or during. It's more or less a general state of complications that by force of things make things happen in parallel. And that requires a parallel type of approach, where you could ideally merge one approach with the other approach. But that's the wishful thinking, and that's the conceptual, I would say, ambition that the majority of donors that I'm working with tries to achieve. Now, in administrative reality terms, nevertheless, if you are, for example, a bilateral public donor, like the one I'm representing right now, you have certain types of, how could I say, of procurement policies that allow you to strike certain types of partnerships and not necessarily others, because you're dealing with taxpayers' money, and the accountability is both ways. It's to the recipient countries, but at the same time to your taxpayers. And that is not necessarily contradictory, but it does limit to a certain amount the type of things you can do, and with what kind of partners. So in reality, although you thrive to work in the nexus, you very much depend on what kind of partners are available on the ground that you can potentially support, and what is the framework that you can use for supporting them. So yeah, I would think that striking the balance between these two is actually more difficult than striking the balance between building a system or addressing humanitarian needs, being understood that the people we're talking about are pretty much the same. And being in a humanitarian situation or a more usual situation for these people in that particular setting is a temporary thing in both. It's the same thing, is the same population in different circumstantial situations that one has to address. So it's impossible to strike a balance and remain faithful to the partnership with that particular country, I think.
Great, and I think you raise, thank you so much. You raise an important point in terms of like the thinking around working in the nexus that would ideally be bringing on board both development and humanitarian partners on the same table and leveraging on their strengths. But I think, as we say, this is something that would need to really be, cultivated. So, Mr. McCoy, I will come back to you, listening to what we've had, and it's very clear that you did mention the critical areas that you see gaps being, and we do have partners. We have the NGOs, we have the civil societies, and it seems like we still do have some kind of common ground in terms of what needs to be done. So speaking from the government lens, what would be the biggest opportunities if there was some investments that needed to be made? You mentioned before the challenges that are there, and we can hear there's a really critical issue coming, or one area to consider is around coordination, which in a lot of countries, I think the ministry takes center stage, ideally should take center stage in coordinating the actors and all that. So what would you see if would be the priorities in terms of really ensuring that we are achieving that kind of coordination and that we are beginning to address some of these challenges to universal health coverage in South Sudan? Sorry, Mr. McCoy, I think you're muted. Sorry.
Thank you, Dr. Caroline. I think I just want to go back to where some of the panelists has really provided very, very important points that can actually enable us to see the way forward. We have seen a long-term engagement, partnership. For instance, we have heard about the history of AMREF engagement. Maybe it was an engagement that dates back to the initial experiment of an autonomous setting in South Sudan way back in the 70s as a result of the brief peace agreement that followed to the first civil war. And then Dr. Kawa and Dr. Barbara really put together some really very important elements that actually can contribute to the aspect of moving forward to build a system that will realize universal health coverage. But let us actually see where we started. I think the enthusiasm of the CPA, the efforts of the first health policy, the second, the current version of the health policy, if you see clearly, the bottom line is really all the necessary elements to realize universal health coverage. It is all about primary health care. It is all about the basic package for health and nutrition implementation. That is well articulated in the different documents for implementation of the health policy. Now, at this point, we are not there because the data shows that only about 46% of the population have any access to the services with all the investment that we had. Late last year, the Minister of Health, I think, came out with a communication that I think should be an eye-opener. And I think it's an opportunity for all the stakeholders to try to take a brief moment and try to understand that communication from the Minister of Health. Because the Minister of Health is trying to highlight a point that look, we have been together. We have really put a lot of effort, but we are not reaching there. From 2017, the Minister of Health came up as a final effort to address the issue of the access to services and build the Boma Health Initiative. I think it has been highlighted by Maurice, and Dr. Kawa also highlighted to the importance of these community-based institutions in advancing the very basic services that can improve maternal and child health, and of course can also address issues related to communicable diseases and all other determinants at the community level. Where are we with the Boma Health Initiative? I think there is a moment for us to reflect on the guidelines that the Minister of Health has communicated late last year. What did the Ministry of Health say? It highlighted a few things, that with all the journey that we had together, we still have a problem. There is a problem of no balanced, satisfactory healthcare distribution. Of course, the political dynamics had not helped also the process. There is also no satisfactory strides towards a functional primary health care. That was what the Minister of Health is trying to flag. There is no significant health care human resource development as persistently proclaimed. Capacity building became a theoretical proposal that is not realized. These are real issues that the Minister of Health is raising. No measurable achievement made in trying to realize those key targets to realize for sustainable development goals. So I think the Minister of Health is trying to say, hey, wait a minute. We have everything. It is not the absence of policies. It is not the absence of plans. It is a matter of reorganizing what we have. The Minister of Health recognized that, in fact, the Minister of Health recognizes the fact that the government's ownership has waned over the years because also the government contribution to health has reduced. And that created a situation where there is now complete dependence on external support. And that, in a way, created a situation where the leadership function of the government is also, in a way, undermined. Okay. So we believe that we have the elements in place. We have the policy, we have the health sector development plan, we have the Boma Health Initiative. We have already institutions that are able to do coordination. The problem is there is not only one institution that is involved in coordination. There are different coordination institutions, and sometimes those coordination institutions work in parallel, and that creates a situation, a confusion. So the Minister of Health is trying to say, let us streamline coordination. If we streamline coordination, we'll be able to make sure that everything from planning our interventions to monitoring implementation to making sure that we have a mechanism to monitor the procurement and even the investment into health. It becomes a joint effort. So with that, we believe that the Boma Health Initiative is actually a viable option for us to realize universal health coverage, because it is a structure that builds on community structures. Communities will always be there.
Great. So allow me to follow up on that point with Dr. Kawa, and thank you so much. I think those are really, really strong and valid points that we need to really think about. Dr. Kawa, I know you might be leaving soon, but just building on to what Mr. McCoy has mentioned, again, it came back to what you mentioned around the coordination. And with coordination, we need to think about accountability. We need to think about, basically the sustainability in the same length. So in your own experience, you mentioned, with especially working with the civil society organizations, what is your take around the level of accountability for local health, for health, especially working with the local health authorities? And can you recall, like, what have you seen? Like, are there areas that need to be like kind of strengthened around that, especially when delivering some of the life-saving interventions? We've had that we are really, there's a lot going on, but again, the impact may not be felt as much if we do not also have that kind of coordinating mechanism. And also from the CSO perspective, or in your own experience, what is your take briefly around the accountability of local health and CSO to health?
Yes, thank you, Dr. Caroline, one more time. Issues related to accountability, ensuring accountability of the local authorities, or the health authorities in general within the country. I think involving them upfront from day one, from the planning stage, through the implementation, through the monitoring and evaluation, through the last stages of projects that are being implemented or the services that are being delivered, being it long-term or short-term. So I think involving the health authorities in the country, in the state, the county for South Sudan is, it's called a district in other countries. So the county is the equivalent of a district. So involving the counties. I will give you an example of that. When I was working with one of the NGOs at some point, and we were delivering services in various states in the country, and in several health facilities, around 4 big health facilities that were serving a big population. But then came at a point whereby the donor was changing the policy in terms of funding these projects. And we started sensitizing the local authorities from the national level to the state, to the counties, to even the service providers in the hospitals, sensitizing them. This is the situation, this is what's happening. We are now in the transition. But that ignites a sense of responsibility around within the authorities, within the health authorities. And they came up with a no, you cannot do that. You cannot wake up in the morning and say, I am going. The people need the service, we are not ready. Let's negotiate a plan. And we came together as the organization, and with these local authorities, we laid out a plan. And that plan was 3 years phase out, whereby in year 1, the organization put in the 75% of support, and the government or the local authorities provide 25%. Year 2, 50%, 50%. Year 3, we give 25%, the government gives 75%. And that was immediately accepted because that they were involved. And when it came to year 2, the concerns of the community, the concerns of the service providers, the healthcare providers, the concern was not coming to us. It was being directed to the local authorities, to the healthcare local authorities, to the Minister of Health, to the county health department. What is the fate? How are we going to get the drugs? And they were in a position to answer those questions. So they were put on the spot. So when we need to include the local authorities in the planning upfront, knowing what's happening, because they are the leaders in that sector in their communities, and that also ensure the transparency when you involve the stakeholders in a given situation, especially in the situation of South Sudan. So I would just conclude that we, by them in the lead, we keep them at the spot, we keep them at the accountability position to the people. Yeah.
Great, thank you so much, Dr. Kawa. So I'll come to you, Mr. Morish. We've had quite some perspectives in terms of what really needs to happen. A lot is happening. Mr. McCoy mentioned about the current gaps. There's a still need to bring together like healthcare workforce. There's need to continue investing in capacity building. There's so much going on, but we still need to come back. So as AMREF Health Africa in South Sudan, what is your take in a very brief way, maybe over the next 2 minutes or so? What would be the role? What do you see AMREF, having achieved so much in South Sudan, but what role would an organization like AMREF play in promoting leadership? Where do you see the connections happening with what really needs to be done?
Thank you, Caroline, for that question. And then thank you, Dr. McCoy, Dr. Kawa, and Barbara. I think I will come from the different things that have been mentioned by my colleagues in the panel. Starting from what Barbara says, that there is only certain things that you can do with a certain aid being given to a community, right? And the money that is available has conditions for what it should do because of accountability issues. At the same time, you have the local capacity issues, gaps in a situation like South Sudan. So how do you bring the community or the people that are being supported to understand these issues around what they can do and what they can achieve with what is available? So AMREF Health Africa have been working with the government. We have established a very strong collaborative working efforts where in everything that we do, there is very high level of involvement of the ministry, of the people that are being served at the community through their different structures, and making sure that they have adequate and enough information to be able to, make a decision and do something. We started initiatives, very interesting initiatives, where we implement models at community level for community intervention to ensure community are empowered with information, with the messages, with the kind of knowledge that they need to get, so that they are involved and they're able to participate effectively in solving their own problems, their own health problems. We have cases like in Maridi, where we're implementing community-led solutions to address the issues of nodding syndrome. Where the community themselves are taking lead in that and ensuring that they're able to understand what their issues are and how they can work with the different partners, the different community members to address that. We have also a case in point in the WASH sector, where we have established women leadership to mobilize from friends to colleagues to relatives to neighbors to be able to address their own problems when it comes to water hygiene and sanitation. And they themselves sat down and during the mobilization, they were able to identify themselves and call themselves as safe water champions. So I am a safe water champion in my own community. Are you one? They ask their neighbors, they ask their communities, and they're doing that. They're being able to take leadership. They are able to hold their members of the family accountable for hygiene practices and sanitation practices, ensuring that they have access to safe water and educating their own colleagues. And we also work together with the ministry pilot program for 14 health facilities, where the issues were so many in the CMOC centers, in the BMOC centers. The nurses, the doctors, the clinical officers, the teams were not working together. And what we did was to do an initial baseline assessment together with the Ministry of Health, identify the issues, and we realized that the issue is not about leadership, management, and governance. There is an element of teamwork. So we came up with a very good curriculum where we integrated teamwork as part of the activities at those facilities. And they started slowly by having regular meetings among themselves, documenting these meetings, identifying their own needs, and also being supported by colleagues from those facilities. We had identified different stakeholders. The UNVs are working in those facilities, but they are supporting these people to be able to document properly their issues. If the staff has an issue with a fellow staff, they're able to sit down and point to management and say, you know, this is something we can work on. If it is the issue of supplies from the Ministry of Health, they know these are issues of supplies, and maybe at the facility they're not aware of where exactly they should go. They work through these colleagues and make sure that they channel their issues to the Ministry of Health. And this has worked quite well. And we are seeing significant change in the behavior, in the practices at those facilities, and those and those colleagues that are working in those areas. There is a lot more collaboration, even with other NGOs. When NGOs come, they're able to sit together with them and say, you know, we have priorities ABCD. This is our priority. And when they come with different priorities, they're able to sit and negotiate. And lastly, I think, I think we are also promoting a lot more of evidence generation and being able to discuss whether with the donor or with the different government officials or departments and community members to understand what this evidence means to them. I will give you a case in point where we are able to resolve staffing issues in about 35 facilities where, you know, we had to look at evidence of the need for those staffing, and we're able to go and sit with the donor and say, look, this is what we have on the ground. And regular communication. Communication is very important in this. Ensuring that information moves from one point to the next, and it's correct information with evidence. People are able to change the way they perceive, the way they prioritize, the way they plan, and the way they execute their plans, and also the way they hold themselves accountable for the needs of the community and the needs of the different actors involved in supporting the health systems in the different locations that we are working. So back to you, Caroline. I think I've taken more than 2 minutes.
Thank you, Mr. Morris, for that. So I'll come back to Barbara, Dr. Barbara. So I've had through these discussions that there are specific country needs as far as you know, I mean, getting equitable and accountable health systems are concerned. But I think one of our speakers also talked about sometimes donor-driven priorities that sometimes may sometimes be in tandem or not really like align. And a lot of the times what ends up happening is that programs drive, there's what's donor-driven and what's maybe, you know, it may be kind of getting off what maybe the Ministry of Health wants in terms of immediate priorities. So my question to you is, is there room for this kind of, you know, discussions in terms of what donor funding could do in a country, and then how do countries maybe, you know, what principles or priorities would guide, for example, a donor when they are looking at country, investing in certain country or in a country like South Sudan. So like how does that really align? Because it seems there's a felt need, and then there's also what is really being driven. So how do those, is there a point at which there could be better, like, you know, coming together of the two and really helping support the key goal of strengthening the systems?
Yes, so I think there are several factors here that deserve being highlighted. I'm not sure I can tell them all in 2 minutes, but there is a time factor that's quite critical for donor funds utilization, which oftentimes is a challenge for good dialogue and good understanding of what's really at stake on the ground. I think there are maybe not enough anthropologists and social scientists and historians that actually take care of identifying the needs and discussing with the local populations or whatever is available on the ground. That's one thing that sometimes comes into the way of really taking the time and understanding what's needed before deploying. There is another maybe bias of the industry itself, which is tempted to do good and which tends to be maybe excessively proactive in offering solutions, because that's what it does, that's why it exists, and that's what donors want to see most of the time from the partners, is use the money wisely and bring a solution. So there is a bit of an attitude of fixing problems before even understanding what's there, because although we might have countries, and here I have to apologize to the audience, maybe South Sudan is one of the particular parts of the world where I have very little experience, but from other contexts, what one would say is that even when the setting is terribly under-resourced, resource constrained, and where the trust towards the authorities is really low, and where actually nothing seems to be functioning, you might have weak institutions, but you don't necessarily have a weak society. So the aid industry is not operating in the vacuum that we all believe it does. There is actually a lot going on that might or might not be initiated by local authorities. It might also be initiated by a number of other actors and dynamics from the society itself. Then one would need close contact and lengthy contact to understand properly. But there is this drive of thinking we're operating in the vacuum, and therefore there is a certain right to build something that's called unexisting. We have to build a system as if no system were existing on the ground. That's another factor. The third factor, I would say, and I'm not really talking about principles, but rather factors, because principle is a really wishful thinking. There is a lot of leave no one behind discourses. There is a lot of do no harm type of policies that are used by donors to sort of frame their interventions, or to frame the partnerships that they are trying to build. But that is really a discourse level. What I'm really trying to come down is to the reality of the engagement of a given donor. So I think another factor that needs to be considered is that there has been a lot of discussions around the definition of what's a post-conflict settings, or what's a crisis or humanitarian setting, what's a fragile setting altogether. And we all come to an agreement that this definition is very unilateral. Somehow it assumes that there is a bad or failed mechanism that's going on in the context. And by bad or failed, we always point at the governance mechanism that's in there. So there is a failed state idea behind protracted crisis. And maybe that idea, but this is my personal opinion out of several years of exposures by now, the failed governance leads to a willingness to fix a health system at the same time as we're trying to fix a state. And there is a little bit of an overlapping between these two concepts of what it means to build a system without having to build the state at the same time. When you are in this kind of context where crisis or chaos or complications are the norm, maybe that's already a system. There are actually several systems that are going on in parallel, and the focus exclusively on building the infrastructure or building the institutions as a proxy to building a health system might also not be always the correct one. That is not necessarily a principle donors are driven by yet, because I think precisely as I was trying to say at the beginning, there is not enough time that's dedicated to understand. But there is something that Mr. McCall was saying at the beginning that I think is fundamentally true. He came back to the history of the country. A number of things were functioning or dysfunctioning before even we thought about building a state, and coming back to why certain things are the way they are and what kind of societies are we dealing with. It's utterly important, and that should come first before a donor principle. Unfortunately, the time limit that was mentioned before is a critical element beyond which you cannot benefit from the funds that are made available. So you have to strike a balance again between doing something or doing nothing. And what's the cost of doing nothing is something we are also not talking sufficiently about, I think, to answer this question. Sorry for taking too much time.
Great. I think that's very clear in terms of what you have raised, and I think this is a conversation that really needs to really deeply happen and really look at what really would be the the sequence of actually achieving this sustainable universal health coverage. But I think what I hear from the panelists is that there's quite a number of pieces that need to come together on a table and really have a well-charted way forward. I think this has really given us food for thought. Now, we've had a lot of great questions coming in. I know time has been a factor, but I'm going to pose a question to you. I think I'll pick two, but what we will do from our organizers is that we are going to pose these questions to the moderators, appropriate moderators, and maybe they could also respond in writing probably after this. But let me pose the first question that we've been asked. I think this will go to you, Mr. McCoy. So is there specific sub-specialized medical training which is required or emphasized for doctors wishing to operate in post-conflict setting at special school or government programs?
Can you repeat the question again? What sub?
Okay, sure.
Yeah.
So is there specific subspecialized medical training which is required or emphasized for doctors wishing to operate in post-conflict setting or at specific schools or government programs?
Well, I don't think I will be in position to cite one, but I think the one key thing that is important here is that if you are operating in a post-conflict environment, and then the bottom line here is to make sure that you invest in local mechanisms that builds resilience. For instance, if you need to be able to realize health service in post-conflict areas, sometimes some environments are so difficult that you may not be able to bring a team from one location and try to be able to sustain services in some of those locations. The bottom line will be to make sure that you build locals, build the capacity of locals who have already built natural mechanism of resilience to be able to sustain their presence in those areas. Now, let me just give an example. It may sound crazy. South Sudan is in the process now of eliminating guinea worm disease. Way back, something about 11 years ago, South Sudan accounted for over 80% of the cases in the whole world. Today, South Sudan is way ahead in the process of eliminating guinea worm disease compared to other countries that has better structures. How did this happen? It happened because we built on local capacity. We built on mechanism for resilience. Every time we think in terms of
Mr. McCoy, did we lose? I think we may have lost him. Okay, all right, okay. Sorry about that. So I think time is not on our side, but I'm going to just ask each panelist in 30 seconds to give us one parting shot, what you need people to kind of take away from, not take away, but really one thought or parting shot for this session. So we'll start with Dr. Kawa, please.
The message is that it's high time to take the leadership in health sector in South Sudan. It's a collective leadership, but most importantly is the leadership of the Minister of Health with the support from all the actors, if it is bilateral or the UN or the international NGOs or the local NGOs. So I think it's high time for leadership, stepping up and take responsibility. Yeah.
Thank you so much, Dr. Kawa. And Dr. Barbara, please.
Yes, I think I would repeat something I said before. Don't assume you are operating in a vacuum. invest in the dynamics that are already existing. There is nothing better than the society itself to know what it needs.
Great, thank you so much. Mr. Morish?
Thank you, Caroline. For me, is that we need to remember when addressing universal health coverage in countries like South Sudan that we are trying to break the cycle of shocks, building people's capabilities and capacities to be able to deal with those shocks. And when we fail to do that, it can lead us back to the state of fragility and ultimately poor health outcomes for the population. So we have to make sure that we are able to reverse that. And we aim to improve people's health in this state. So we need to address the health system that exists. Even if, however weak it is, we build from what it's already in place. In terms of empowering the people around the health system, empowering the health workers who are working in there, building national leadership, different levels of leadership in different levels of the community. And with that, we can realize universal health coverage. Progress, though it will be slow, but we will be able to do something.
Great. So thank you so much. I think, and to the audience, one thing we can say is that we see that this is a conversation that needs to go on. I mean, we've just touched the tip of the iceberg. It was so great having the representation from different lenses to the issue and quite some very good takeaway points. I think the bottom line from where we stand, or where I stand, is that we cannot leave fragile and conflict-afflicted settings behind if we are going to really, truly achieve universal health coverage. So necessary conversations, investments need to be happening. But most important, what I've taken from the discussions I've had is that coordination is really key. We can do so much, but without a coordinated effort, we may not be really seeing the fruits of the efforts that we are putting in. I want to thank all the panelists, Dr. Barbara, Mr. Morish, Mr. McCoy, and Dr. Kawa. Thank you so much for that engaging discussion and the perspectives. I think we've all learned a lot. And for your time, I know this is where some of the parts of the world we come from. I think the sun is setting at this point in time, but we have kept it here. And to the audience, participants who've joined us, thank you so much for staying on this last session of the day. Usually we get very low, audiences, but I see we have really sustained a good number. So I hope we have taken something with us. And for the questions that are not answered, I know there are quite a number, I think about 4. We are going to give them to the specific panelists, and if possible, we'll request the panelists to just take some time to think through the question and give some response. It may be very helpful for the participants. Mr. Jacopo, thank you so much for the great coordination of this session. So I will applaud, and I'll applaud to everybody and ask everyone to applaud for themselves. Thank you. And yeah, we will come to the end of this session. I'll hand it over to the organizer. Thank you. Great. Mr. Jacopo, all over to you. Thank you. Okay, great. I guess the session is over. Sorry, I thought they'll be giving some bit of comments, but thank you. Oh, he's connecting. Okay. Great. Mr. Jacopo, are you online?
Yes.
Great.
They've actually cut the power even here, but thank you. I managed to join with the phone. I really thank you all. It has been a great and very interesting conversation.
So thank you so much, everyone, and have a great day, evening, and night. So until see you tomorrow for an exciting day. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye. Yeah.